Hi, my name's Esther Youd. I'm a consultant histopathologist at the Royal Glamorgan Hospital in South Wales. Today I'm going to take you through general aspects of death certification with some additional specific notes on coronavirus.
So this is a talk that I have given to every new junior doctor starting in the hospital for the last 10 years. And I've obviously updated it recently with some aspects of coronavirus, which we'll come to towards the end. So I'm going to run through the death certification principles, reasons for referring deaths to the coroner, a little bit briefly about the medical examiner system, and then talk about the Coronavirus Act in the UK and the implications for death certification, and then talk about some COVID-19 related deaths and how you might certify them. So to begin with, certification of death and verification of the fact of death are not synonymous. So particularly as a junior doctor, you'll be called to the wards to verify that somebody has died, and you'll perform the checks of whether there's any breathing or heart rate, etc., and you'll verify whether they've died. Often the terminology is mixed up, and you might be asked to certify that somebody's died, but what we're going to talk about is writing a medical certificate of the cause of death, which is the death certificate. So certification of death is a statutory requirement under the 1953 Births and Deaths Registration Act in the UK, and we often find that it can be done poorly, and that can be for lots of reasons, but particularly confusion regarding the death certificate itself. And in Wales that's doubly confusing because there's lots of writing all over the form, and it's written in two different languages, English and Welsh, so there's even more writing on the form and it's all very small. But the form does guide you as to what you should do. There's often quite poor training in how to formulate causes of death, and that goes right the way through from medical students through junior doctors and even to senior doctors. But there is lots of sources of information that you can go to for help, including some really helpful guidance in the notes at the front of the death certificate book. If you look on the back of the death certificate, there are also some guidance notes, particularly about things like occupational related deaths. And if in doubt, just ask a pathologist. We're really quite experienced about certifying causes of death, and we are a friendly bunch, so we'll be able to give you advice. So the format of the death certificate is the same across the world. In part 1A, you write the immediate cause of death. In 1B, you write any condition that gives rise to 1A. In 1C, you write a condition that gives rise to 1B, which gives rise to 1A. So you're working backwards during 1C to 1B to 1A. And then in part 2, you list other conditions that have contributed to death, but you should really think carefully about how they have contributed to death. It's not a place just to list every medical disease that somebody had. You've really got to think, how did it contribute to death? And I always ask myself the question, would they have still have died of whatever you're putting in part 1 had they not had what you're putting in part 2? And we'll go through some examples in a moment, and that will illustrate that point. Just to say as well, you don't need to complete all of 1A, 1B, 1C. You might just have one condition that is the immediate cause of death without any underlying causes that have given rise to that. So it's fine just to write something in 1A and nothing in 1B or 1C. So here are some examples. The first example is death from congestive cardiac failure with underlying ischemic heart disease. So the ischemic heart disease has caused the congestive cardiac failure. So you've got that sequence working from 1B to 1A being the immediate cause of death. The second example is of a streptococcal septicemia due to a streptococcal pneumonia with diabetic nephropathy in part 2. So this is a good example of where something in part 2 has contributed to death but hasn't directly caused it. So here you've got a pneumonia and you've grown streptococcus from the blood cultures or from sputum cultures, so you know what the organism is. And it's really helpful to be as specific as you can be on the death certificate. So if you know what an organism is that's causing infection, do include it. Here we've got something in part 2, so diabetic nephropathy here has contributed to death. And the argument is that if there hadn't been diabetes, perhaps somebody might have coped better with the infection that they had on board and the treatment for it. Whereas with diabetes, and particularly with renal involvement, that treatment of sepsis and the associated acute kidney injury, for example, on the background of chronic kidney disease, may have made the response of the patient to that treatment less effective. So therefore, you can consider that diabetic nephropathy has contributed to death. The next example is of liver failure due to alcoholic liver disease. And this is another example of where you can state an organ failure, such as liver failure, as long as you qualify what the underlying cause of that is, in this case, alcoholic liver disease. And then the final example is one where you have two important conditions that are both troubling the patient at the time that they have died, and you can't necessarily decide which one of those is the most important in causing the death, or you might think that both of them have contributed to death equally. So it is okay to put two conditions down together in a cause of death such as that. So some unacceptable causes of death. You can't say cardiac failure without qualifying what the underlying cause is. So we had an example in the previous slide of a liver failure which was qualified by what the underlying cause of that was. So you can't just write 1A liver failure. There are multiple causes of liver failure, some of which are natural causes, some of which are unnatural causes, and you need to state what the underlying cause of that organ failure is. Cardiac failure is actually one of the exceptions to the rule here, and you can have somebody dying in congestive cardiac failure without necessarily understanding what the underlying cardiac pathology was. But actually that's really quite rare, so do think about whether there is underlying ischemic heart disease or valve disease or hypertension, for example, that have been the cause of cardiac failure. So you don't often need to rely on that as an exception. So don't list modes of death like shock or coma as a cause of death. It's not helpful on a certificate to include what the mode of death is, so do think about what the pathology is, because that's the purpose of the death certificate, is to record the pathology. And the last example, 1A pneumonia due to 1B rib fractures. Now this is a perfectly acceptable formulation of a cause of death. The reason that I say it's unacceptable is if you are a junior doctor coming to write a death certificate for somebody who's died in hospital, then this is not an acceptable cause of death because it's an unnatural cause of death and it requires referral to the coroner. But you can, in your referral to the coroner, state your opinion about the cause of death as stated, and that will help the coroner decide how he then investigates further. So when do you complete a death certificate? Well, you have to have seen the patient within 14 days. Now that's slightly changed under the current Coronavirus Act rules, which I'll come to slightly later on. But in normal times, you need to have seen the patient within 14 days of death. And usually if you're a junior doctor in a hospital, that's not normally a problem. But in cases where somebody dies in the community and you might be a GP, then it might be slightly longer than that since you last saw the patient. You need to know what the cause of death is and know that it qualifies as a natural cause of death. And as I've said, on the back of the death certificate, there's lots of really useful information about unnatural causes of death, including occupational causes of death. So do have a read of that. You need to know that there are no issues of public interest that require addressing, because this is the role of the coroner. And if there are such matters, then you will need to consider referring the death to the coroner for further consideration. And finally, if you don't know what the cause of death is, and therefore you can't complete a death certificate, don't ask the family for permission for a post-mortem. If you can't give a death certificate, you can't give a cause of death, you need to refer the death to the coroner because the cause is unknown. And then the coroner will need to instruct a pathologist to carry out a post-mortem. Now this is done as part of that legal system under the rules, and it's not something that the family can give their permission for or withhold their permission for. So you don't want to get yourself into that sticky situation of having asked the family for permission for a post-mortem because you can't write a certificate and then them refusing. So do explain to the family that you don't know what the cause of death is and that you need to refer to the coroner and that a post-mortem might be required. Just don't ask them to give their consent. So some recommendations about what you do when you complete a death certificate, and these are taken from an audit that we did of death certificates some years back by a junior doctor at the time who was interested in a career in histopathology and is now a consultant in histopathology. But these recommendations still are appropriate. So avoid abbreviations. You need to write everything out in full. So if somebody died of pneumonia due to COPD, then you need to write out in full chronic obstructive pulmonary disease. Do write legibly on the form and make sure that you spell things correctly as well. Ensure that the underlying cause of death is something pathological. If somebody has died of a pneumonia, do think about what the underlying cause might be, because pneumonia is a really common endpoint of many different types of disease. And so it's always useful to think about what the underlying cause might be and to then include that in 1B so that you do capture that underlying disease. For example, pneumonia is a common endpoint in lots of people dying of cancers or of chronic lung disease, so you need to list that as the underlying cause. Old age is acceptable on a death certificate. The rules are that it's acceptable over 70 years, but in general, we'd advise caution unless they're over 80 years. And there's a typical history that goes along with somebody dying of old age, and that is a slow, gradual decline over a period of weeks or months, with a loss of interest in life, in enjoying friends and family, loss of interest in eating or drinking. No specific medical problem, but just this gradual, slow decline, and then death. And in those circumstances, it's appropriate to write old age as a cause of death. We're very lucky to be supported by excellent bereavement officers, and these people will offer assistance when you're writing a death certificate, but they don't make medical decisions. They are not doctors. They will help you facilitate all of the paperwork that goes around the whole process, and they will be a key person to communicate between the hospital, the relatives, you as doctors and undertakers. And when they call you, please do respond promptly to requests to come down and complete certificates. The offices in the bereavement office have computers and a desk where you can complete your paperwork, and they will provide any advice and support about how to complete the paperwork or how to complete a referral to the coroner. And just to note, the medical examiner service is being introduced across England and Wales. It's not yet in place in Wales, but it will be over the coming months or years. And this will slightly change what happens through the bereavement office. So what happens? You'll be called down to the bereavement office. The hospital notes will be available in the office, so you don't need to bring them with you. We require a conversation to take place between you and an independent senior doctor, who's often a pathologist, but not necessarily, before you complete the death certificate. When medical examiners have been appointed, you'll be required to talk to the medical examiner about the patient. So get all the information together that you possibly can. Prepare it like you're going to present a history, and be ready then to have that conversation with the senior doctor. If the family have opted for cremation, then do complete the cremation form at the same time, and that avoids any delays to the family making funeral arrangements. So when do you report a death to the coroner? Well, in October 2019, the notification of death regulations were released, which set out for the first time the specific reasons for reporting a death to the coroner. So if you don't know what the cause of death is, then you need to refer to the coroner. If you haven't seen the patient within 14 days, you need to refer. If the cause of death is unnatural, and this includes poisoning, exposure to a toxic substance, death related to drugs, either prescribed or illicit, if it's a violent death, if it's due to trauma, if it's due to self-harm, if it's due to neglect, including self-neglect, if it's related to a medical treatment, and this includes operations, or if it's attributable to employment. If somebody died while they were in police or prison custody or otherwise in state detention, then you need to refer the death to the coroner. And this includes deaths whilst detained under the Mental Health Act. And finally, if you cannot identify the deceased, then you can't write a death certificate. So how do you report a death to the coroner? Well, any person can refer a death to the coroner. In this hospital, we complete a referral form electronically. You give as much information as you possibly can and don't leave out anything that you think could be important. Remember that the coroner and the coroner's officers are not medical, so please use layman's terms and explain any medical terms. We transfer the form to the coroner's office electronically and the coroner will make a decision. Sometimes he will say he doesn't want to investigate the death any further. You should tick part A on the back of the death certificate, which says you have referred the death to the coroner, but it's for no further action. And then you should complete the death certificate as usual. He may decide to hold a post-mortem, or he may decide to hold an inquest without having a post-mortem. You may be asked to provide a statement for inquest, and if you are, then please discuss that with your team, particularly your consultant, to make sure that your statement is consistent. In general, the decision to complete a death certificate is a medical one, and the decision to hold a coroner's post-mortem is a legal one. So you have to think, from your point of view as a doctor, can you give the cause of death to the best of your knowledge and belief? And that's the level of certainty that you need to reach. It's not that you're absolutely 100% certain this is the cause of death, but you need to be sure to the best of your knowledge and belief. And if you're not sure, then you refer to the coroner. If you do refer a death to the coroner, it's only polite really to inform the family that you've referred the death and that you can't say what the cause of death is, so that they know they'll be contacted by the coroner's office to discuss what happens next. Just a quick word on postmortems. There are two main types of postmortem. Postmortems mostly occur at the request of the coroner. This is about 99% of cases across the UK are coroner's postmortems. They don't require the consent of the family, and in general they're not there just to answer clinical questions. There's a relatively narrow remit to determine the cause of death. You can get a report following a coroner's postmortem if you're interested to hear what happened to your patient. If you just contact the pathology secretaries, they can facilitate that with the agreement of our coroner. The second type of postmortem is a consent postmortem, and this is where you know what the cause of death is, but there might be some aspect of the death or the disease involved that you want to know a little bit more about and that a postmortem might help you with. In this case, you have a discussion between the consultant, a pathologist, and a person in a qualifying relationship with the deceased, which is usually a family member. And this will take the family member through what a postmortem is, what the purpose of the postmortem might be in this specific case, and will ask them several questions about what they give their consent for or not. You do have to complete a death certificate in this case because the family could withdraw their consent at any time and you still need to be able to issue a death certificate. A quick word about cremation forms. These attract a fee, but you do need to remember to declare all of the income that you get from cremation forms because HMRC will follow up any untaxed income such as that. On the form in question 5, you're not the usual medical attendant, but you're the F1 attending the patient during the last admission or something similar. Question 9 is a big box to give as much information as you possibly can about what happened to your patient and how you've come to the conclusion about the cause of death that you've provided. You do need to say whether a pacemaker or another implant is present that might be pressurised. Pacemakers, if they go through the cremation, through the crematorium, can cause an explosion, so they need to be removed prior to the cremation. But removing it isn't your responsibility. That will be done by the funeral directors by and large. And again, with cremation forms, the bereavement officers and the senior medical staff will help you through the form. So in summary of this first part, death certification is really important. It's important that we know why people die so that we can then put money in the right places in healthcare to prevent causes of death. Remember, your duty of care remains in place after somebody died, so please do come down to the bereavement office without any delays to complete the certificate. Get as much information as possible so that you're ready to have a discussion with a pathologist or a senior medical person. Don't leave anything out, and be guided by the bereavement officers. They've got so much experience and they can help you through all of the different pieces of paperwork. Remember, if you sign the certificate, it's a legal document and you're responsible, so take that seriously. And remember that medical examiners, when they're introduced, will change this process slightly. So moving on then to aspects of coronavirus. So in the UK, the Coronavirus Act of 2020 introduced a number of different changes to the processes around death certification. And this was aimed at addressing the potential for a large number of excess deaths to be seen during this pandemic. It tried to smooth the process of death certification and reduce the numbers of postmortems that might be required. So I've given you a link to the guidance from the National Medical Examiner's Office, which is really helpful. So in summary, some of the changes, now any doctor with GMC registration can complete a death certificate. It doesn't need to be the doctor who looked after the patient, it can be any doctor. The number of days in which the patient has been seen has now been extended to 28 days, and it now includes if somebody has been seen by video consultation, so it doesn't have to be a seen in person. The death certificate can be scanned and sent electronically to the registry office. And this is really helpful where you have people maintaining physical distancing during this period, so families are not required to come into the hospital to collect a death certificate and then to attend the registry office. It's all done electronically. COVID-19 is an acceptable cause of death, which raises a slightly interesting point that it's an exception to that rule around abbreviations, since COVID-19 is an abbreviation of coronavirus disease, but there we go. And the informant, the person that actually takes the certificate to the registry office, can be not just somebody, a family member, but it can now be the funeral director or a hospital official or someone similar. COVID-19 itself is not a reason to refer the death to the coroner. It's a natural cause of death, but it is a notifiable disease. Usually that notification to the public health teams will have been made by the laboratory that confirmed the disease. Cremation Form 5, the second part of the cremation form, has now been suspended, and now any doctor can complete Cremation Form 4. And examination of the body isn't required if the deceased was seen within the 28 days prior to death or has been seen after death for verification. So COVID-19 is an acceptable cause of death, but do consider the comorbidities. So if somebody has died with significant underlying disease, it's really important that you think about what the underlying cause of death might be. So for example, we know that things like diabetes and hypertension and obesity increase the risk of the development of COVID-19 and of getting worse symptoms and ultimately of death. So it's really important that these comorbidities are expressed on the death certificate, either as direct underlying causes of death or as contributory factors. So don't just write COVID-19 in 1A and nothing else. Then do think about whether the person died of COVID-19 with it, so has it just been there present, or has it exacerbated other existing disease, or is it entirely coincidental? Is the death related to something completely different, in which case it probably doesn't deserve to be included on the death certificate. It's really important that we get accurate death statistics around deaths related to COVID-19. And one of the things that will need to happen from the Office of National Statistics will be taking into account excess deaths from all-cause mortality. And this is something that is regularly done. For example, in influenza pandemics, the ONS will look at the excess deaths that have occurred over a period of time, over and above what you would expect for that period of time normally. And they will make the assumption that some of those deaths, or perhaps all of them, have been due to or exacerbated by the infection at the time. So influenza in the past, or this would be related to coronavirus. So we'll just go through some cases. So the first case is an elderly man, a care home resident, with a medical history of COPD, type 2 diabetes and dementia. He's admitted to hospital with shortness of breath, cough and fever. He has a swab of SARS-CoV-2 which is positive, and despite treatment in hospital he ultimately dies. A reasonable death certificate would be 1A COVID-19, 1B COPD, obviously spelt out in full rather than abbreviated, and type 2 diabetes mellitus as a contributory factor. So there it's really important that the underlying comorbidities are recognised and reflected on the death certificate. And you might also want to include dementia in Part 2 as a contributory factor. The second case is an elderly man with a medical history of Parkinson's disease who develops a fever, is admitted to hospital, has a swab which is positive, and develops a pneumonia which is shown to be Streptococcus pneumoniae, and he dies despite treatment in hospital. So a suitable death certificate would be 1A Streptococcus pneumoniae pneumonia, 1B COVID-19, and Part 2 Parkinson's disease. So here we're saying that there was a superimposed bacterial infection that developed on the background of the viral infection from COVID-19. And it's really important that both of those are recognised and reflected on the death certificate. Case 3 is a middle-aged man with a medical history of angina. He's had a recent SARS-CoV-2 swab which was positive. He went upstairs in his house to the bathroom and was heard to collapse suddenly. He was found in cardiac arrest, and despite calling an ambulance, he was unfortunately declared dead. So this is not the mode of death of COVID-19. So this is not necessarily related to COVID-19. You need to consider whether it is or not. It's likely that this is a cardiac cause of death, and it probably requires an autopsy to establish the cause of death. If an autopsy found that there was evidence of ischemic heart disease, then that would be very suggestive of an arrhythmic sudden death in keeping with the circumstances of death. And then you would have to consider whether COVID-19 played any role in perhaps exacerbating that existing ischemic heart disease, so therefore contributing to death, so included in Part 2, or whether it's coincidental. Case 4 is an elderly female who was driving to the supermarket, who collides with another vehicle and is killed instantly. An autopsy shows multiple injuries, and a SARS-CoV-2 swab which was taken before death was found to be positive. This again is a death that's not due to COVID-19. This is a death that's related to multiple injuries following the road traffic accident, and the fact of the swab being positive is just coincidental to the death. So take-home messages about COVID-19 and death certification. COVID-19 is an acceptable cause of death, but do consider the underlying comorbidities and include them in the death certificate. Not all people who die with SARS-CoV-2 infection die of it. Do think, Did they die of COVID-19, with it, or is it entirely coincidental? And remember that the all-cause mortality death data will take into account deaths where coronavirus may have exacerbated pre-existing disease. So after that statistical information is examined over several months, we'll have a better idea of the number of people who have died related to COVID-19. Thanks very much.